Hello, everyone. I'm Eva Salikian. I am the interim chair of the Department of Pediatrics, the Stead Family Department of Pediatrics. And I would like to welcome you to this webinar today. And Dr. Schultz will introduce Dr. Wellington.
Well, thank you, Dr. Sleekian, and welcome to everyone who is taking time from their lunch to join us here. This is our first in what I hope is a series of lunch and learns. They're taking the place of the Pediatric Provider Council dinners that we used to do back pre-pandemic. Some of you may have participated in those, and hopefully you'll get a sense of what sort of activity would take place at our Pediatric Provider Council dinners that at some point I hope we can return to. The presentation today is going to be by Dr. Melanie Wellington. It's about COVID-19 in children. Please mind the open parentheses knowledge, close parentheses gap. I love the title. I will have her present the lecture she's going to be giving, but there are opportunities for you to type questions into the question box that you'll see on the right-hand side of your screen. There are also some questions that I thank some of you for sending in ahead of time, and we'll see how we do for time, and we'll try to get to questions as they come up at the end. So thank you very much, and Dr. Wellington, thank you for taking time out of your lunch to join us here today. And I'll pass the baton over to you.
Well, thanks, Tom. Welcome, everybody. You know, we're all finding our way through the pandemic and the wonders of technological meetings. So please make sure you let the organizers know if something happens to my sound or my video. Let me know so that I can fix things. But thank you all for coming. And yeah, I was kind of trying to figure out what to title this talk, and actually when Tom first approached me about giving the talk, I was thinking, what will I say? Because there is such a gap in our knowledge about what's going on, and that made me remember the time in the London subways or underground, which I was a teenager when I went there first, and I was fascinated by these signs everywhere that said, mind the gap. And of course, that usually is the gap between the platform and the train. But if you're not careful, it could also be the gap between the platform and nothing, or worst case scenario, the platform and the moving train. And sometimes I think that's a little bit about what we're doing here with COVID. Sometimes we want to walk out and know what we're doing and there's nothing there. And sometimes we want to walk out and know what we're doing and zoom, we're going someplace else immediately. So that's sort of where we've been, and I'm going to try and give you at least a little bit of what we've figured out so far and some thoughts about what we can be doing right now. And I guarantee everything in this slideshow was accurate about an hour ago, so I'm sure something has already changed, but we'll have to just sort of deal with it as it goes along. So here's our outline. The brief history of SARS-CoV-2 is where we'll start, and I called it the brief history rather than a brief history because, well, its history is quite brief. The first document that we know of that reported that this viral infection was starting came from the Wuhan Municipal Health Commission. I am told that this is the alert that they put out, and I am also told that this is what it says. Forgive me if that's not the case, but basically they had noted that there was exposure to the South China seafood market in Wuhan had resulted in patients presenting with pneumonia of unknown cause, one after another, was how they had phrased it. That notice got picked up by a couple of health watch organizations, including several that the World Health Organization uses to keep an eye on things going around the world, and it rapidly became big news. It was only 10 days later that the investigators sequenced the virus and knew this was a coronavirus and a viral pneumonia. And that still boggles my mind. Sometimes we make comparisons between the 1918 flu pandemic and the COVID pandemic, and it was in the 1940s that we figured out that the influenza virus was the cause of flu. And for COVID, as much as we don't know, we at least have the tools and the science and the technology to really increase our knowledge at a pretty impressive pace. And the WHO acknowledged the Chinese authorities for doing this and pointed out that this preliminary identification of this virus in such a short period of time was a notable achievement and demonstrates China's increased capacity to manage new outbreaks. And then most of you know this history, but just to remember how fast things have gone through. It was 12 days later that someone had died of the virus. 21 days later that there was a patient here in the US who had traveled here from Wuhan. And by January 30th, just 1 month into the outbreak, the World Health Organization named it a public health emergency of international concern. That's only been done, I think it's 6 times now. It's a relatively new designation, but it really has been part of how the World Health Organization acknowledges how fast these things can move with current global travel and everything else that's going on. And so they very rapidly designated it a concern. And again, Italy and then the US and then Iran all had their sort of moments where things were happening. The disease was named February 11th, which I find very interesting that we had the entire genomic sequence for the virus and we didn't have a name for the disease it caused until a month and a half later, actually a month later. And in case you were wondering where COVID comes from, here it is, it's coronavirus disease. And then a month and a half into the outbreak, there was an outbreak in Iran, and 71 days after the first description of the pneumonia, the world pandemic was declared. Again, just phenomenal speed, both of technology, both of communication, and unfortunately, if also the virus spread as well. And it was but before the end of March that the US had the highest number of confirmed cases in the world, which isn't really a record that we want to keep, however. So COVID first came to Iowa from what is now probably an infamous Hills Bank Friends Club travel program. Apparently Hills sponsors these travel outings. And this particular one was people had cruised on the Nile River from February 19th to March 2nd. And 21 passengers on the cruise were from Iowa. These cruise ships are very small. And so you wouldn't, it's not like the Diamond and Princess cruise ship where they have 3,600 people, right? Most of these ships probably have somewhere between 60 to 200 passengers. But the problem is there aren't very many docks. It's like every cruise ship wants to go see the pyramids, right? So when all of the cruise ships that are going to go see the pyramid that day, there's one dock. And the first cruise ship that gets there ties up to the dock. The second cruise ship that gets there ties up to the first cruise ship, and on and on and on. And my brother actually went on one of these cruises with my dad, and he heard this story about how COVID came to Iowa, and he said, I am not surprised at all. He told me this story of how these things dock up. And if you're cruise ship number 13 and you want to go see the pyramids, you actually walk through the lobby of cruise ships 12 through 1 to get to the pyramids. And then on the way back, you have to walk back, and there's a person on your ship very carefully watching for the people that belong on that ship, and they take you, here, you're home, go to your cabin. So this is sort of a silly story, but the point of this is our society, our global culture and society now is set up in a way that there is so much travel and communication and cultural exchange, and some great things come out of it. But we've also never set ourselves up for a way to protect ourselves from everybody in the world. And we all know that that's become a massive challenge. And I think it's taken some shifts in our thinking, and I think we're partway there, and I'm sure there will be new challenges coming up tomorrow. But basically, that's how COVID came to Iowa. It would have come here some other way, for sure. But of the first 13 people in Iowa who were diagnosed with COVID-19, 12 of them were on that cruise. So you see, it still was here. It wasn't just a cruise. I'm not trying to blame Hills Bank or the pyramids, but that's how things got started here. And we do a lot of comparison of COVID outbreak to other pandemics. This is a sort of graphic of the great pandemics of history. I'm not sure I would call them great, but okay. And these little fur balls are different pandemics, and they give you the number of people who died from various different things. And the size of the fur ball is the size or the number of people involved. And here's the 1918 flu outbreak in green. And then here's COVID in red, and this was as of September 21st. So it's completely different already. And the reason that they had shaded this in hashed lines here is because they knew it was changing. But just to give you some comparisons there, the 1918 flu pandemic, I think, is an interesting comparator. We've talked about the timing, obviously, was much slower, but things were different then, but not completely different. So about 500 million people, or a third of the world population, had flu by the time the pandemic was over. A significant portion of that was because of global travel, which at the time was very new. It was from World War I, which was an unbelievable mixing of people that hadn't happened before. And there were huge political controversies. There was a lot of talk about what would be the impact of flu on the war effort, which was basically the economy of the time. And there were politicians who would go out to this, the New York City mayor being a famous comparison because it was completely different, saying New York City will never be in danger of this virus, making blanket statements and denying risks and fear-mongering and promoting risks. There were mask mandates, they were issued, they were moved too early, they were ignored. There was a huge debate about whether or not kids should be in schools. So you see, some of this is starting to sound disturbingly familiar. One of the big differences I would point out, though, is that kids transmit flu like mad. We all know that. We take care of these kids, right? But kids give other kids flu, kids give adults flu. The school closings with flu were actually critical to control of the outbreak. And we'll talk more about how that relates to COVID later. My maybe favorite parallel, of course, was the U.S. Surgeon General prescribed salts of quinine for people who had flu, which I find very interesting because if you look at quinine here, it has this sort of tangle of atoms up here. If you were to unwrap that tangle, you would end up with this molecule, which is chloroquine or hydroxychloroquine. So we use these molecules when we don't know what else to do. And we now know that this was not a very good choice for COVID. It wasn't a very good choice for flu either. But it's part of the process of working our way through pandemics that we have to try new things and find new information. So that's the brief history of SARS-CoV-2, maybe a little bit of flu thrown in there. And that takes us on to sort of what about coronavirus? What do we know? Well, there were 4 strains of what we now are calling typical or traditional or sort of upper respiratory infection or common coronaviruses. They cause about a third of the colds each year, and there are millions of cases per year with a very low mortality. The coronaviruses are not the ones that we think of as only happening in January or paraflu in the fall and spring. They're year-round transmission of the common cold. And their source is us. So there's a constant reservoir of coronaviruses of people with the cold around the world, and we just pass it around one after the other over and over again. And as you notice, I said over and over again because it's not something that you end up with lasting immunity to. And that is something that we worry quite a lot about when it comes to people who have been infected or vaccine strategies. But you probably have all learned by now R0 or R0 as a factor. But just to remind everybody, it's an estimate of, given sort of standard conditions, for every one person who is infected with a virus, how many other people will be infected. So it's a marker of infectiousness. And it's something that we follow very carefully right now because it's a marker to tell us how much we are controlling or not controlling the pandemic. But for coronaviruses, the R0 is really actually pretty low, 1 to 2 people infected per person who's infected. And you would think, wow, how would that possibly cause the common cold outbreaks that we see? But remember that if it's 2 people for every person, that's exponential growth. And that's bad enough. There were 2 other more pathogenic or novel coronaviruses that have come up in this century. The first one was SARS-CoV-1, which at the time was labeled SARS-CoV. And it came out of southern China, and the major sort of North America component of the outbreak was in Toronto. And overall, there were about 8,000 confirmed cases. It, just like the current virus, probably came from bats, maybe also from civet cats, and had a mortality of 10%, so not insignificant. This is an estimate, and we'll talk about that as we go along, but as an outbreak is evolving, it's not possible to really get a great handle on mortality because it's a relatively straightforward thing to do to count the number of people who die in an outbreak, but it's not so easy to know how many people were infected in the outbreak. Certainly that's been a big issue with our outbreak now. But anyway, this 2 to 4 R0 for this and the 4 R0 for MERS-CoV-2 are within hospital outbreaks, and in large community populations, the thing that kept these things from turning into a pandemic like SARS-CoV-2 is that there are not in a population that's actually much lower. And for whatever reason, they were if it was at 2 or 4 in the hospital, for whatever reason in the population it was lower, and that enabled public health authorities to contain the outbreak. We still see cases from time to time coming up with MERS-CoV-2, but the numbers are definitely declining. And for SARS-CoV-2, we talked about Wuhan. We think that the original source was from bats. Most of the viruses that we have as humans come sooner or later from another animal source. That's where things tend to get rearranged. This is a slightly old slide, so it's talking about probably around 40 million cases. And as best as we can tell right now, mortality is around 2.5%, or around 1 million people have already died globally, which is obviously a tragedy. This is one of several very beautiful, I guess you have to be a molecular biologist to think of it as beautiful, but I do, images of the virus itself. And this is the infamous, this gray and blue thing, the infamous spike protein, and it binds to the ACE2 receptor on human cells. And this is a very busy slide. Don't worry, obviously there's no test, but you don't have to understand this to understand the rest of the talk, but it's to remind me to mention a little bit about how disease happens. And like many viruses, the virus itself has a mechanism for attaching to a cell. In this case, it actually attaches to ACE2 receptor, but there's a complication of cleavage, and it's always more complicated than you think it should be. But the virus enters, it unpacks, it makes more of itself, and they're released. And that's the viral cycle. The problem, of course, is as with most viruses, is the host response cycle. So the cells are being damaged through this process, which is highly inflammatory and recruits a lot of innate and adaptive immune cells to the environment. And there's a tremendous amount of cytokine release in the local environment. That's not the MISC, that's the actual active infection. And the same thing happens with flu and most other viruses. One of the reasons why it's so hard to come up with an antiviral medicine that would stop the common cold is that by the time you have the common cold symptoms, almost all of your symptoms are from your host response, not the virus itself. So that's a little bit about how the virus causes problems inside of us. And then there's a question I mentioned about mortality. And it's very difficult, again, to get a handle on this, but it's very clear now that if you look at us as an entire population, the infection fatality ratio, or of the people who are infected, how many die, is very different than other viruses we talk about. You hear in politics all the time, COVID is not just flu, or COVID is just flu. But I'm here to say that it is mostly not just flu, but it depends on your age. I'm not trying to actually make any political statements. I totally believe COVID is not flu. But we're talking about COVID in children, so we need to really mention the impact of age, because for whatever reason, we as pediatricians have gotten kind of lucky with this one. We still don't know why. There's a bunch of different hypotheses out there and lots of active investigation. But the younger you are with COVID, the better off you are. So what this graph is that infection fatality ratio. In other words, for each person who's infected, how many percent, how likely are they to die? It's a log scale. And the red lines are estimates for the COVID outbreak, different studies for different lines. The blue lines are the infection fatality ratio for flu. And the different lines are different years of flu. And if you're looking at these age range, we usually use this cutoff of 40 years or older, which definitely includes me, so I'm not calling that old. But 40 years or older, what you see is this difference. So the infection fatality ratio of flu is much lower than that for COVID. And remember, this is a log scale, so this is like 10-fold difference here. Obviously, it's not flu. But if you look down here in the sort of 0 to 10 crowd that most of us think about treating all the time, it depends, right? So 2017-18 and 2018-19 flu years were not that bad. relatively speaking. And so they had a pretty low fatality ratio. There were very few pediatric deaths. But the 2016-17 year had a lot of pediatric deaths. And so that's this blue triangle, I'm sorry, the 2017-2018 year, blue triangle wide lines here. And as you can see, even given most of the estimates for case fatality of COVID, some of the bad flu years are actually worse than COVID for the very young. And we'll come back to that, but it makes a difference in how you think about that and how we deal with it for our patients. And where we need to worry for our patients may not be about the patients themselves, but about the adults around them. And this is just another way of sort of comparing that. If you look even just up to 34 years old, which it definitely is not 0 to 10, but the infection fatality ratio is very low for COVID. In fact, lower than the chances of dying by an automobile accident or another accident. So we need to keep that in perspective as we go, because I think there's so much fear mongering in the media that we need to remember. If you are like my mom, 85 or older, this is a massive difference. COVID is not the flu, nor is it a car crash, but this changes with age, and it really needs to structure our responses. So what about kids, though? They clearly are different, and so I've put some data in here about how kids present, and it's not so easy. This is a meta-analysis where they looked at all the individual kids who presented with various different symptoms, and here are their symptoms and the percent of kids who had those. And in this particular meta-analysis, they found that 16% of kids were asymptomatic throughout the entire infection. Different studies estimate that at different levels. I've seen numbers up to 45%. Yeah, do with that what you will. But fever is, as with many viruses, the most common presenting symptom, but after fever comes cough. But all of these very non-specific symptoms can happen with presentational kids, and that's our big challenge, right, is sort of sorting through who do we worry about and who do we not worry about. And it gets even harder, okay, because it's not a presenting symptom complex like we're used to seeing. It can often be a presenting symptom singular. So in this particular meta-analysis, they had about 15% again who were asymptomatic. But of the kids who had a symptom at presentation, 44% of them presented with a single symptom. So 23% of kids, and this is a meta-analysis, right? So that it's looking at a lot of studies. We had a fairly large number of kids in this analysis. 23% had a fever, period. 5% had cough only. A lot of people say to me, well, I can't, you know, operate that way because I would be thinking every kid I see has COVID this winter. And my answer to that is yes, you should. In fact, actually, you should operate under the assumption that every human being you see has COVID all of the time. But as far as taking care of your patients, you do need to operate under the assumption that all of your patients could have COVID at any minute. For just under half of patients, it's a symptom complex, a little bit easier, things we're more used to seeing from viral illnesses in kids. But really, remember, this group here is going to be a huge challenge, especially as we go farther into respiratory virus season. And so that brings me to one of my, probably if you had taken one point and no other point from this entire talk, this is it. There is only one way to know if a patient has infection, and that's to ask a microbiologist. So this is Brad Ford. He's the medical director of clinical micro here at the University of Iowa. And those of us who practice here or near here owe him a huge thank you, because he's been tirelessly working to keep our testing volume up. And we have huge testing capacity here in a way that most people around the country don't. And we can really use that to our advantage as we go through respiratory virus season. So just a little shout out to Brad there. But the point being, testing is the only way to know. There are all these like things out there that are like little like podcasts and stuff. How do you know if you have the flu or COVID? It's like, if you looked at the symptom list, there's complete overlap. The only way to know is to test. There are kids out there who have a UTI and a fever from UTI and COVID. So just finding another reason for their symptom isn't enough. Kids with diabetes who present with COVID, you know how they present? DKA. Adults too, not just kids. But, you know, I mean, it's not something that we can take for granted anymore that it's just one thing. Okay, COVID is common enough right now that it's going to be happening in kids who have other stuff too. Testing is really your only major approach to that. And that brings us into transmission and figuring out how to sort of figure out what's going on. And I titled this section Stepping into the Gap, because we had to start this knowing nothing, and we had to kind of step into that airspace and hope we didn't get hit by the train. Maybe there were a few little train incidents, but there you go. This is a general sort of timeline for any viral infection. You get infected, there is some incubation period of time. At some point, if you're going to develop symptoms, you develop symptoms. And so that's called the incubation period and the symptomatic period, because epidemiologists are fortunately not creative. Makes it easier to understand what we're talking about sometimes. And then there's the infectious period, right? That's the window during which you can give it to somebody else if you're infected. And also for COVID, there is a pre-symptomatic, in many viruses, a pre-symptomatic but infectious period. And that's the kicker, right? Because that's the, like, how do you block transmission when you don't even know you have it? So at the beginning, here's our gap, right? We're going to have to step into this gap. We don't know the incubation period. We don't know the infectious period. We didn't know there was a pre-symptomatic but infectious period. How are we going to figure all that out? So to start with, infection, the incubation period is not that hard, because there are plenty of patients out there where they had a single exposure. There's only one known exposure. Maybe they had other ones that they didn't know about, but if you look at a lot of people, you can kind of wash that out in the numbers, and you just measure the time from the known exposure until the symptoms. So that's the incubation period. We're pretty good on that now. It is from 2 to 14 days with a very, very strong median at 5 days. But what are you going to do about the rest of this? Where is the infectious period? And that was obviously a massive thing we had to deal with early in the outbreak. So what can you do? Well, you get two patients, one who gave the infection to the other, and you do this over and over again as often as you can. And you study something called the serial interval, because you don't at that point know the incubation period even, and you don't know the infectious period. What you can measure is, when did symptoms start in patient 1 and when did symptoms start in patient 2? And that difference is called the serial interval. Now, if patient's infectious only after symptoms start, then this period is reasonably long when you compare it to the incubation period. But if a patient is infectious before their symptoms start, you can see the serial interval now decreases a lot. And in this particular example that I drew at random, it is shorter than the incubation period. And if a serial interval is shorter than the incubation period, there must be transmission before symptoms start. It's just math. Nothing's usually that clear cut. So when people went to study this, they looked at 77 pairs where one person was clearly gave it to the other. The mean incubation period was 5.2 days, and the mean serial interval was 5.8 days. So pretty darn close. And when they get this close, that's close enough to say, you know what, that's going to be asymptomatic transmission or pre-symptomatic transmission, and that's a problem. Another way to look at this, and another way to think about testing, is this data that came out again as surveillance data from Europe. This is a little complicated graph, but it'll get us there for a couple different points. This is days from symptom onset on the x-axis. So some patients were exposed and had a known exposure, and so they were tested before they developed symptoms. So that's why there are dots over here on the negative side of days from symptom onset. And all of the people who were in this section of data eventually got symptoms. So none of the asymptomatic people in this group. They had, in this particular set of people, the ability to actually culture live virus. Not something that we recommend you do at home. Kids, don't try this there. Anyway, but in very careful facilities, they cultured the virus. So we do, for our testing, the PCR test. And it's a quantitative PCR test, which means it reads out in something called CT values. We talk about that later if you're interested, not important. But the basic idea is that the lower the number, the more virus you have. So we'll just call this hot instead of low, because low gets confusing. So if your CT value is very hot, there's a lot of viral RNA in the sample. And if your CT value is very cold, down by 40, that's our limit where we say values below 40 we're going to call those negative. So one thing you can first see is all these different dots. There's tons of them that are above 40. They're hotter than 40. And we know this now. This is the problem, that people who have COVID frequently have PCR tests that are positive for a long time. So the PCR test doesn't test for contagiousness. right? It tests for the presence of the RNA. And that's why what this study did was so important, because it also cultured live virus. If you can culture live virus out of somebody's nose, they're contagious. And do it carefully, please. So the blue dots are samples where they could culture the virus and detect it by PCR, and well, just culture it. And the black dots are where they did not detect live virus by culture. You can see there's a ton of overlap because that's the way biology works. But one very important thing to focus on here, check this out, right here at day 10 is a very abrupt demarcation. You do not see any blue dots on the right-hand side of day 10. This is where we get our isolation period from. In otherwise healthy people who are not like in an ICU with COVID or who are not immunocompromised, virtually never is there a detectable live virus after day 10. And that's why we say from symptom onset to day 10 is when somebody who has the infection needs to be away from other people. We still pick it up on PCR for a long time. Don't let those PCRs, influence you too much. And then another way to look at this again now is to do a regression analysis, which is more complicated than my brain usually goes to, but the basic idea is what % of people were culture positive at what time, again, days from symptom onset. And you can see they were culture positive, a large portion of them before symptoms started, and then again, this dramatic drop off at day 10. So that's what we know, and a lot of other studies, I didn't want to go too far into that, but the basic summary is a person who is going to be infected or is infected is most contagious at days -2 to day 5. The -2 to 0 is the kicker, of course, and the asymptomatic people as well, because those are the people who are walking around, interacting with you at IV or in your office or wherever, spreading virus. And that's why it doesn't matter who you are, you should be wearing a mask. Good news is those interactions when you're paying for your groceries at Hy-Vee are what we call casual contacts or short contacts, and those are very, very low risk. You need to have what's called a meaningful or close contact, really, to exchange enough virus to become infected. So don't freak out about Hy-Vee, but do think in your office about where people are going and how much time they're spending together. And that's where that 6 feet and 15 minutes comes from. And that suggests that the major, by far, mode of transmission is respiratory droplets or short-range aerosols. This term aerosol is an epidemiology term. It gets used with different definitions. It's kind of a bugaboo. I wouldn't bother going there too much. But the basic gist of it is these respiratory droplets, there's plenty of them in front of me right now. They don't have COVID in them, hopefully. Not that I know of for sure. Right, there's plenty of them in between me and the camera. Can't you see them? No, of course you can't. But they go out as we speak, and the more powerfully we speak, or if we sing, right, they come out a lot. And these droplets fall to the ground. They are large enough that they are acted upon by gravity, and they fall to the ground. Those are respiratory droplets. Airborne transmission is when the droplet that has the infection in it is so small that it's more affected by air currents than by gravity. So they stay in the environment a long time, especially the smaller the room, the lower the air exchanges, the more they stay there. The dirty epidemiology secret is it's not one or the other. It's a spectrum. Bummer. More on that in a minute. Anyway, it's possible to have contact transmission, but I think this is where maybe there's a major difference between flu and COVID, because if you think about how kids give each other flu in daycare and at school, there's a lot of contact. There's a lot of face slime that gets put all over the classroom, and then more contact, and then more face contact. And it's where you have to put your infectious disease hat away and put your mom hat on when you go to pick your kids up at daycare. So flu, tons of contact transmission. COVID, thank goodness, very little. It's possible, but very uncommon. Okay, airborne transmission. These are when the droplets are so small they hang out in the air, and all you have to do is be in the same airspace with somebody and you're in trouble. Is that happening? Spoiler alert, gray zone, but pretty much not. Okay, here we go. So one way to look at that is to look at the R0. Airborne transmission is unbelievably efficient. Right? So the classic airborne transmission is measles. For every person who gets measles, 12 to 18 other people are infected. Thank God for vaccines. Anyway, and if you are in a household with somebody who has measles and you have not had it or not been immunized or not have been sufficiently immunized, right? 90% of those vulnerable people are going to get it. That is true airborne transmission. It doesn't take many particles to become infected, and those things hang out in the air forever, right? And that's what you see when the primary mode of transmission is airborne. That's what you see. And you don't see that with COVID. You see it with chickenpox. You see it in a slightly different way with TB. TB is an interesting example because kids don't transmit TB very well either, right? It's always the adults that give it to the kids. Interesting thought. There's probably some good biology to learn there. Come back in a couple of years and I'm sure I will understand it. Anyway, but COVID, right, has a relatively low, compared to these guys, attack rate, high enough to be causing a world pandemic of dramatic proportions. But the household attack rate also fairly low. If you live with someone who has COVID, 10 to 30% risk of becoming infected yourself. That's really hard to, I still can't figure out how that is true, but it is, okay? And that's because, again, you have to have this sort of respiratory droplets that sink to the ground pretty quickly, and you have to have a lot of them. It is, however, extremely variable. So this is a map of COVID transmission in various different places that were studied. And for each one of these dots, you see an arrow. So this is the person who was infected first, and then the arrow goes to the person that they infected. And over here is the majority of cases, right? They infect one person, maybe 3 people. That's where that R naught of 2.5 comes from. Then there are super spreaders. Super spreader events are these ones where, and you can see here, 19% of infections are responsible for 80% of transmissions. Kind of like mosquito bites, only different. And they are associated with particular social phenomenon. This one was in a bar. This one was at a wedding. This one was at a temple. So they're places where they are social gatherings where there's a lot of people in a small space, where there's a lot of talking, singing, cheering, listening to bar music, so you're talking really loud to the person who's right next to you. That's where, this is where the major outbreaks are coming from, and 69% of infections, so there are all these dots that don't have arrows going away from them, don't transmit to anybody. So one wonders sometimes how this is a pandemic, and this is how. So again, super spreader, you need prolonged contact, the ventilation, we talked about these things, and that's what leads us to the 3 C's, which are closed spaces, crowded places, and close contact settings. And when all 3 happen, forget it. And that's why we see so much transmission associated with bars. Just saying. My new joke, right, is an infectious disease specialist, an epidemiologist, and an ILI clinic person go to a bar. Just kidding, they know better. Okay, so that brings us to prevention. The prevention measures, you have heard these over and over again, right? You've heard about distancing, you've heard about masks, you've probably heard about eye protection and limiting gatherings, restricting travel, don't go to bars. But that's only half of it, right? So the other half is detection, contact tracing, isolation, and quarantine. So I'm not going to go too far through some of this. This is the sort of Swiss cheese model. You've heard about this before. The more layers of Swiss cheese you have between yourself and the virus, the less likely the virus can get through the cheese, right? So keep all of your cheese layers lined up as much as possible. So we'll run a little low on time. I want to leave time for questions and think for just 1 second about which part we're going to go over. Okay, I got it. Mask data, I think you probably have seen a variety of different studies with a meta-analysis. If people without masks had a 17.4% chance of getting infected versus 3.1 if you had a mask. Same thing for distance and eye protection. This we're going to skip. And this is just real quick. These are projected infections moving from here where we are forward. If we have just sort of what we currently think of as is going to happen is this line here. If we have more social opening, things get bad fast. But if we could all wear masks, by January, there would be 127,000 fewer cases per day. I'm just going to let that one speak for itself. 1,000. And this, it doesn't have to be perfect. If we can just drop R0 a little bit, we can make major changes. So if you do nothing, R0 is 2.5. We know that. If you have some distancing, some mask, you do some small thing. If you could make it by half or a quarter, you can make a big difference. If you could drop it to 75%, or so for every person who's infected, 0.6 people are infected. At day 30, 2.5 people would be infected. If you can drop it by half, 15 people are infected. If you don't bother to wear your mask and distance, 30 days. Okay, but that brings us to us and what can we do, right? Because all the different public health organizations in the world are working on helping prevent this. But sooner or later, it's going to come down to us and our relationship with our patients. And they are going to come to us and hopefully believe us as much as we possibly can. So that brings us to the gap, which is what you're going to do in your practice. And I think the single most important thing you can do is combat fear. So this is one of my heroes. You probably recognize him. I won't mention that he says that size has nothing to do with it. I'm 5 foot tall, but that is not why he's my hero. He's my hero because of his wisdom. And obviously it's not his, but and he's not the first person to have said this, by the way. But fear is the path to the dark side. It leads to suffering, anger, and hate. And for whatever reason, political, media ratings, you name it, there's a lot of people peddling fear out there. So I think maybe our job is to try and do what we can to not walk to the dark side and help our patients know some real answers. So here's a nice slide. You can totally see all these numbers, right? We're done. No, just joking. So this is came out from the CDC in September, so data through September 19th, and they looked at different parameters of school-age children and COVID. And I hate graphs that look like this, so I'm making it look like this. And so basically, this is the age group, all kids, 5 to 11, 12 to 17. There's not much in the way of gender issues. And here's again some estimate of who had symptoms and who didn't. In this particular case, there are fewer asymptomatic people, so no symptoms is asymptomatic, 5-ish%. But remember that when we're talking about COVID infections in studies of kids, we're really not catching anywhere near the majority of kids because we haven't been testing kids very much because of the outcomes, right? And this is the important thing. If you take all 5 to 17-year-olds in the US from March through September 19th, 3,000 of them were hospitalized. 3,000. All comers, not just healthy kids, but all kids, 51 deaths. Every single one of those deaths is a tragedy, and I am not trying to minimize it by what I'm about to say. But going back to my thing about fear, right? This includes, okay, MIS-C as well. So these are kids who died with a diagnosis of COVID. Some of them died from something that wasn't COVID, but the way it gets counted is if you have a COVID diagnosis and you die, you're counted, okay? So again, I'm not trying to minimize those deaths. They're really disturbing, okay? But here we go. So if you do the math, we have a little under 300,000 known childhood infections that were in that study, 51 deaths. So that's 1 in 5,500 kids who are dying with COVID. There are wide-ranging estimates of how much we're undercounting cases because we just can't test everybody, and that's changing over time too, which makes it very hard to keep track of. But a sort of middle of the road estimate, I promise I did not take best or worst case scenario. Middle of the road estimate is that we're probably counting about 1/10 of the number of cases that are out there. Okay, if that's the case, then we're talking about 2.8 million kids in the US have been infected so far. We don't tend to undercount the deaths. The reason that we undercount cases, right, is because people are asymptomatic, they don't know how to have it. They had symptoms, but they're a kid and they were unlikely to have complications, and we needed to save those tests for the people who were going to have complications. People didn't want other people to know about it because now there's a stigma, so they didn't get tested. You name it, okay? But when somebody dies, we're pretty good at counting that, which we should be, right? So if there's underreporting, it's going to be in the number of infections, not in the number of deaths. So if you do that math, you're at 1 in 55,000 kids are dying with COVID. And if there are 74 million children in the US this year, and if every single one of them got COVID, and if we made no improvements in our ability to recognize and treat disease, then you're talking about somewhere between 1,300 if you're talking about known cases, or 13,000 if you're talking about estimated cases of kids who will die with COVID, not from COVID, right? And to put that in perspective, if some of your patients are just sort of in this fear land and you need to help them pass that, in 2016, 4,000 kids died with a car crash. 3,000 children died by firearm injury. And comparing that to somewhere in between 1,300 and 13,000 with COVID. You know, I mean, if this was all COVID was, if COVID didn't bother adults either, then the answer to COVID would be to go out and control gun safety, right? And again, I'm not trying to minimize COVID. It's really important, but we need some things to hang onto to sort of communicate with our families who are so scared. There is a legitimate fear, right, that if a kid has COVID, they would give it to grandma, right? And I'm not trying to minimize that one either, but we need to be able to say these things. And the other big fear, and the way this always comes up, is with school. Nobody talks about the risks of not opening school. Have you noticed this? People are finally actually starting to get at some of the mental wellness and other issues about abuse and services and everything else. So finally, people are starting to talk about the risks of not opening school, but everybody talks about the risks of school reopening. Here's one of the many pieces of data now that make me think this is not that big of an issue. It looks like spaghetti, and that is the point. Okay, so don't worry if it looks like spaghetti to you, it looks like spaghetti to me. What this is the daily cases in any particular country, a 7-day moving average, and again, on a log scale. They took each country and took the rates of infection, and they made day 0 be the day schools reopened. Okay, so here's what's happening in the country before schools open. Here's a nice example, South Africa, right? Rates are going up. They open schools anyways. What happens? Rates keep going up, slope is the same. Germany, down, slope is the same. Denmark, down, slope is the same. Madagascar, I worry about, right, because they did have a spike. Israel had an interesting spike, which is here, it's this buff colored line, and they were continuing to go down for several incubation periods, right? And then they go up. You know what happened? They removed their mask mandate. Just saying. The point being here that whichever direction most of these lines were going before school was opened, that's the direction it keeps going. Okay, and you can make any argument you want to. I can make as many arguments and show you as much data as you want to about whether or not kids are likely to transmit to adults and whether or not 3 feet or 6 feet is enough for school, etc. This is huge global populational data with, I don't know, what is that, maybe like 10 or 15 countries that opened their schools in the real world, not in a research study. And it didn't matter much, if at all. So there you go. There's my ways to tell people not to be afraid. And then what are you going to do just in the last few minutes? It's, again, asymptomatic patients presenting with vague symptoms are going to have COVID, and we need to find those kids so that we can get them isolated and quarantine their contacts in order to get past this outbreak. And that is hard because totally looks like every January in my pediatric practice, right? So again, the only way to know is the test. And here's my example of overlapping etiology. Here's a kid in school, gets incubation period, gets symptoms, okay? And the infectious window is 2 days before the symptoms start, 10 days afterwards. And he goes sent home from school when he gets the symptoms, and he gets a test, and it's positive here, and we put him in quarantine, and that's great, right? The problem is that he sits next to kid B, who was infected here, right? That kid, with this particular timing, is at home in quarantine before they are infectious. Fantastic, but that's not always the case. And sometimes it's not really the case at all. And so same quarantine, right? Now you've got this kid at school spreading it to his friends, and this is how it goes, and more, right? So test early is rule number 1. Right? Anytime you think a kid has COVID, test them now. Do not say, well, you've only had fever for a day, let's wait and see if it stays. Don't do that. The moment somebody mentions to you a single symptom that could possibly even maybe sort of sat next to COVID once on the bus, test them, right? So you do that. If you shift the test earlier, right, now you're shifting the quarantine period earlier, and you're catching more of these kids who are now not passing it to other people. And the other rule is test often, right? So if they have mild symptoms, if it doesn't even really sound like COVID, but they just don't feel like eating, test them, right? Because if you don't, they're going to stay in school, and then all this kids are. This is the great thing about being in our area, and I know not all of you can send tests here. If you are sort of on the borderline and you want to know more about how to accomplish that, let me know. We'll see whether or not we can arrange something, because we have phenomenal test capacity here. These are our test results over time from the beginning of the outbreak till this morning. Black is negative, purple's positive. This was when campus opened. I didn't say it. Anyway, but the point I'm trying to make here isn't that. It's look at these numbers. These numbers are not going up because more and more people are being negative. These numbers are going up because more and more people are being tested. And this is 1,300 tests per day here at the peak of the campus outbreak, and we have more capacity now. Thank you, Brad Ford. Okay, we've got the tests. We are very fortunate. Not everybody does. We've got them. We should be using them, because it's by testing that we're going to get ourselves out of this outbreak. Isolation and quarantine sometimes can be confusing. If people have questions about that, we'll talk about that later. But I'm going to go straight to questions now to save a little bit of time for questions. And there is a little clicky thing in your webinar screen that says handouts, and it says instructions to claim CME, or CE, sorry, it's not CME anymore. Oops, forget that. Oh, I wrote it by accident. Anyway, so here's what you can, if you can't get the instructions, there's what you need to do. But I figure we'll just leave that there for you while we're talking.
Melody, I'll give you the applause since I'm the only other one on the screen here. Fabulous, fabulous job. Thank you so much. It covered a lot of ground, but covered it in a very clear and very readily understandable way. So you just did a wonderful, wonderful job with that. There are a handful of questions. There's some around testing that I think you covered really quite nicely. But one, if you talk just briefly about some of the different types of tests, the rapid antigen test versus PCR, saliva antibody testing, just real briefly about those different types of tests, and are there any one better than another, and ones to use early, ones to use in follow-up, and so forth.
Yep. So the PCR test we talked about, right? Viral RNA is picked up by PCR. It's there very early on, usually before the start of symptoms. It actually kind of has to be, because you can't have a symptom if you don't have the virus in there, right? Yeah, anyway, so it's very, very, very sensitive. Probably slightly too sensitive because of the ongoing positives, but that's a different conversation. But very, very sensitive. The false positive rate is virtually zero, or false negative rate is virtually zero. Sorry about that. False positive is a conversation to be had over lunch sometime by Zoom. But it's super sensitive. It's there immediately. Okay, even before you know you have it, it's positive. It remains positive for a long time, which is its problem, that RNA is just super stable and some of it just doesn't get cleared like you'd think it would. So a patient who does not have any symptoms and got screening tested for some reason or another, they were going to fly on the airline and they had a PCR, whatever, if it's positive and they have no symptoms at all, one possibility is that they had it a month ago. So again, with the whole fear issue, people call you up, oh my God, the PCR is positive. Well, you do what you would normally do with the quarantine and the isolation and everything, because you can't know, right? But if the patient doesn't have any symptoms, you can reassure them it's entirely possible that it's already done, right? So PCR testing is your big, broad overview. It's what we do here. It's the gold standard for sure. Antigen tests, so also saliva tests, also frontal nasal swab tests, a variety of different tests are antigen tests. So they are looking for little bits and pieces of virus. They're looking for the chicken nuggets of the virus, right? So that tends to come up much closer to when symptoms start, because that's when the most virus is there, and it goes down relatively quickly again because most of the virus itself is cleared. Some of them have high false positive and false negative rates, most of them, unfortunately. There is an Abbott test that made huge news in mid-August about how they were going to change the world and end the outbreak, because they were going to give us all tests and they would just like test all of us every day and we would just be done with it, right? What happened to that? That test actually has pretty good parameters. It has a little bit, because of pretest probability and some other issues, of a false positive rate, but not much. It's really good if you're using it in people who have acute symptom time period. If you're using it as a screening test, it has some false positives. The Department of Health and Human Services, as in like the federal government, bought all of them, and they are distributing them as they see the need. So we don't have any here. Could we get them? That would be great. But somebody at Health and Human Services is sort of figuring out where the biggest needs are to try to control the outbreak. And whether or not I would agree with that person, I probably would, right? The people who are at that level with this are pretty much down in the data, and it's hopefully not too politically driven. We can't get them now. If we can, we will let everybody know. It'll be on the news. You won't need me. But the only good antigen test that's out there right now is not available to us. If there are antigen tests that the Big Ten is using to test all the football players every day right now, those are the ones, because it's a screening test with false positives. So again, if somebody calls you and says there was an antigen test that was positive, first thing to do is to do a PCR to repeat it. If the antigen test is positive and the PCR is negative, it was a false positive. As you can see, there's total overlap here. Finally, serology. Serology is coming way after the fact and isn't really going to help you much. A lot of people want to have their serology tested, and I think that they just want to sleep easier at night, and I get that. I would love to have us all sleeping easier at night. The problem is it will not actually change the issue, because people want to think, well, if I have antibodies, then I'm immune and I can just go out to bars and not worry about it, and that is not how it works. Remember, we talked about coronaviruses. No lifelong immunity. We don't know how long right now. The CDC is giving us about a 90-day period of, if you've had a PCR within the last 90 days, you don't need to be retested. Partially because it'll still be positive, but partially because during that period, there don't seem to be reinfections. If somebody's highly symptomatic and it really looks like COVID, go ahead and retest them and go ahead and treat them. But the only really good use for serology that I know of, and there are going to be more because that's the way it works, but right now the one I know of is if there were a patient, say, in the medical intensive care unit who had some terrible lung disease and they weren't sure, could this be COVID or was it some occupational exposure they had, or there was vaping. Remember vaping? Remember when we worried about vaping? I wish, right? So, and they're trying to say, you know, how much do we start this big giant workup for these other diseases? Do they have cancer and do we look for it? Or how much do we just think maybe this is COVID? So, and those people are 20, 25 days into their symptoms. So sometimes the PCR is negative. Doing a serology on that patient might help you sort of guide your evaluation for other diseases. Likewise, if somebody's really convinced, really convinced, and somebody's got MIS-C, then they often will do the serology, because if it's negative, then it's not MIS-C. If it's positive, it does not mean it is MIS-C. And I will tell you that looking at all of the patients that we've had here at our hospital who might have had MIS-C, 3 of them had bacterial sepsis. And you do not want to miss that because you think it's MIS-C, right? MIS-C is really much rarer, again, than the news makes it out to be. So if you're thinking about that, do think about it, because it's important to think about. But don't forget that all the other causes are all still out there too. So those are the reasons to do serology right now. It's unfortunately not that helpful. We do not have a way to look at antibody levels or even like IgM versus IgG. So we cannot give you a recent infection or old infection. We just give you there are antibodies. So it's not usually helpful.
Well, it's 1 o'clock, Molly, but there's a number of questions, and I think if you are okay going just a couple minutes over, because this is something that's fairly timely as far as thinking about recommendations for travel and holiday gatherings for the kids. I know this is probably a big topic that is probably a talk in and of itself, but I thought, oh, maybe in a couple minutes there'd be an answer for that.
This morning we were eating breakfast and my 11-year-old daughter put her head down on the counter. I was like, what is wrong, sweetie? I do not want to do Christmas by Zoom. Oh my God. I don't either. My mom is 88. Okay, anyway, yeah, travel. So travel for the holidays, like as in like I am going to go fly to Philadelphia to see my mother, travel.
Mm-hmm.
You can take, if you are yourself low risk and everybody's going with you is low risk and the places where you are going are low risk and you feel that you can take very, very good precautions about hand hygiene and distancing and masks and stuff like that, and you've decided that the mental wellness is a bigger benefit than the risk, that is legitimate. However, remember that you cannot tell who's high risk and low risk by looking at them, and you need to remember that you're going to interact with lots of people once you get there, and you're going to interact with lots of people when you get back. So if you're planning on doing something like that, I strongly advise building some quarantine time into your schedule so that you can have some time alone at home on either end to decrease the risks of that. Don't tell anybody in the epidemiology infectious disease field I said that, because I'll probably lose my membership card, because holiday travel is one of those things that just spreads these things. It was one of the major factors actually in the pandemic starting, another talk. But again, nobody talks about the risks of not opening school. We also need to talk about the risks of not traveling, okay? And there are good legitimate reasons to travel, and there are risks for not doing it. So you need to make those personal choices. But if you do it, you need to do it thoughtfully, intentionally, and in a way that keeps everybody around you as safe as humanly possible. Halloween, I got it easier. That's been the topic of the day. I'm for trick-or-treating. My daughter's going to go out trick-or-treating. She will wear a mask, not a Halloween mask, but a face mask. We will not go any place where they are not wearing face masks. We will not go to the door if somebody else is already at the door. We will not go to the door if it's the door inside the covered porch, right? But if we can go to somebody's house and we are interacting with them, we are all outdoors, right? So again, that gray zone with the airborne outdoors is your best bet, right? We're all outdoors. I know where I'm going, so I trust them to have good hygiene. By the way, my neighborhood has already made a pact about this. And we're all wearing masks and we're distancing, and the person who's giving stuff to my daughter will pick it up, having done hand hygiene, of course, and drop it without touching her into her bucket, so that kids aren't doing this into the bowl, right? That's what we're going to do for trick-or-treating. That's sort of a combination of what one-way and two-way trick-or-treating. One-way trick-or-treating is if you want to give out candy but you don't want to face the risk, put the candy out on the porch, watch and wave from inside your house, or sit in the garage and have the candy be at the end of the road. We're going to have to rely on kids to be good kids and not take the whole bowl, but you know, it's a way to do it. So the same thing for Thanksgiving and Christmas too, or other holidays if you practice them. If you can find a way where you can really confine the amount of people you interact with during travel, and where you can interact with people outdoors, that's your best bet. It's getting cold. I realize that's not so simple, but you know, meeting somebody at a ski slope to ski together would be better than not seeing them at all.
Well, Melanie, fabulous answers. And I apologize to all of you who have typed questions into the question box that we haven't gotten a chance to get to. I'll try to collate those, Melanie, and pass those along to you. And I think we can email those out to people who have participated. There are some pretty pointed questions that I think we can give some fairly concise answers to, so that it's available for all of you to take a look at. I want to also thank all of you for joining in and making this a successful Lunch at Learn. As I say, I think we'll try to aim to do some more of these, and I think we almost could do another COVID-19 talk a week from now with the additional information that comes out. I won't press you on that, Melanie, at this point. Well, again, okay. Again, thank you all for attending, and appreciate your participation. And this is being recorded. We'll get the link out for the review for those of you who would like to listen to this again, or if there are colleagues that you think would benefit from signing in and listen to this, or if they have some interest and weren't able to attend, please feel free to forward along that information. And we'll look forward to seeing everyone the next go then. And Melanie, do you any?
Yeah, if you have specific questions, if it's a complicated situation, if you need an answer right away, I'm available. My email, if you just Google my name, you can find it. It's the standard UIOA email. So if you know any of it's Melanie-Wallington UIOA, feel free to get in touch. We really all need to be taking care of each other, and remember to stay well. Find things that will keep you well during this, because again, those risks are real. So thank you all for listening.
All right, thanks again. All right, take care, everyone.